Hello, everyone. Thank you so much for joining us today. My name is Kirsten Ingraham. I'm with the Duke Cancer Institute's Community Outreach and Engagement Team, and we will begin our virtual training in a few moments in regards to Ask, Advise, Refer, strategies for talking to cancer patients about tobacco use. In the interim, if you have any questions, please feel free to include your questions in the chat. We will be answering the questions at the end of the presentation. Thank you again, and we look forward to hearing your feedback as well as your chat conversation. As a brief overview for the program, we are going to have an overview in regards to the North Carolina Oncology Navigator Association. This information will be shared by Dr. Stephen Paterno. He is with the Duke Cancer Institute, Duke University Medical Center, as well as the North Carolina Oncology Navigator Association. Additionally, we will have information shared by Sarah Arthur, who is the program manager with the Cancer Prevention and Control Branch with the North Carolina Department of Health and Human Services. And she will provide an overview in regards to the North Carolina Advisory Council for Cancer Care and Coordination. Next, we will have an overview from Dr. Ronnie Bell in regards to the Prevention Subcommittee Snapshot. And he is joining us from Wake Forest Baptist Comprehensive Cancer Center of Atrium Health at Wake Forest Baptist. And last but certainly not least, we will go into our training, which is in regards to Ms. Megan Keith. She's been with her team for over 4 years, and she will be providing the training in regards to tobacco cessation training, Ask, Advise, Refer, strategies for talking to cancer patients about tobacco use. And she is with the Duke Smoking Cessation Program. We will end out our program with a session in regards to addressing the questions and discussion points raised in the chat. Up, we have Dr. Stephen Paterno. He is with the North Carolina Oncology Navigator Association, the North Carolina Advisory Council for Cancer Care and Coordination. He serves as the chair, as well as the deputy director for the Duke Cancer Institute. He is also a professor of medicine with the Duke University Medical Center. Without further ado, I pass it over to Dr. Paterno.
Thank you, Kirsten, and welcome everyone to this incredibly important training session. Tobacco cessation among cancer patients is extraordinarily important for many reasons, not the least of which is the improved health allows our treatments to act better as well, and prevention for secondary cancers, as well as cancers among extended family as well. So we're very grateful that you are signed on today to get this training. My job here today is to introduce you first, I think, to the North Carolina Advisory Committee for Cancer Coordination and Control. That organization is a state organization, and you're going to get a lot of detail from Sarah Arthur on that. I happen to be the current chair and governor-appointed advisor to the committee, and I just want to reaffirm to you that tobacco cessation is one of the key initiatives and has been for many years, certainly has been for the decade that I've served on the committee, and certainly in the 2 years that I've been chair as well. We look at tobacco cessation from prevention with respect to, or tobacco control, I should say, from the perspective of prevention, also from the perspective of screening for early detection, and for treatment and survivorship. So you are plugging into a major statewide initiative. And you're going to hear more about that from Sarah. The other organization I've been asked to introduce you to is called the North Carolina Oncology Navigator Association, or we call it NCONA. This is a not-for-profit 501c3 that works closely with the state. When I arrived in North Carolina in 2012, I met with my good friend and partner at UNC, Jean Sellers. Jean was meant to give this presentation today, but she's not feeling well, so I'm stepping in. Jean is the executive director of NCONA, and I serve as its president right now. She and I were the co-founders of this organization. It actually represents almost 300 navigators across the state of North Carolina, and we host annual training sessions for navigators that offer CME credit or CE credit to whoever needs it. That allows people to continue to keep at the top of their game in patient navigation. So navigation is a intervention that began in Harlem almost 3 decades ago, but has expanded rapidly across the United States. It is a position that allows people to help, allows navigators to help people overcome barriers to getting access to care and navigating through the complex labyrinth of our healthcare system. It is a means to overcome cancer disparities. It is a means to support all patients and getting more rapid access to care, more rapid access to quality care, and getting people to and through a healthcare episode, and in the context of cancer care, into survivorship care as well. So the mission of NCONA is to advance the role of patient navigation by providing a network for collaboration among navigators and to promote the development of best practices for improved access and outcomes of cancer care. As I mentioned, we represent almost 300 navigators across the state of North Carolina, and that provides a virtual network, a safety net of sorts, if you will, of navigators who are connected to navigators across multiple health systems. And we try our best to help all patients, to help no one fall through the cracks and make sure that as many people as possible get access to care. As I mentioned, we put on an annual all day, actually almost a day and a half training session. Every year we update people on sort of the latest best practices in navigation. And then during the year, we do separate webinars on very specific topics. So it's statewide. Navigators can be nurse navigators within a health system. They can include social workers, care coordinators, community health workers, community educators, ambassadors, and lay patient navigators. Some systems use volunteers who get trained as navigators and interact with their patients. There's a long history of study of patient navigation, including something that was funded by the National Cancer Institute some years ago. There's been probably 500 scientific papers published on navigation showing its efficacy and its cost effectiveness and its ability to save lives and improve outcomes, particularly in cancer. And so navigation can be important in the community setting. It can be important in cancer prevention, and it can be important in inside of a cancer diagnosis. And in for today's emphasis, can be important within a cancer center or a community hospital in getting a cancer patient and their family who are struggling with nicotine addiction and need tobacco cessation to get connected to the services that are available on a statewide basis. And you'll hear multiple examples today from the 3 comprehensive cancer centers, UNC, Duke, and Wake Forest, as well as, I think, a deep dive into the tobacco cessation program at the Duke Cancer Institute. So I will stop there and turn it back to Kirsten, and happy to answer any questions. If you have any questions, just put them in the chat and I'll try to respond. Thank you.
Fantastic. Thank you so much, Dr. Paterno, for providing that overview. If you could kindly share a few words in regards to the North Carolina Advisory Committee on Cancer Coordination and Control, and the amazing work that you do there, and we will do a warm handoff to Sarah Arthur.
I'm sorry, Kirsten, did you ask me to do something? My audio cut out for a second.
Yes, sir. If you could kindly provide a warm handoff and introduction in regards to the North Carolina Advisory Committee on Cancer Coordination and Control.
Okay, great. So for those of you who don't know, within the state government, there is a branch called the Cancer Branch. There are many different aspects of what the state of North Carolina is doing in cancer control across the state. Those efforts are coordinated and led by the North Carolina Advisory Committee on Cancer Coordination and Control. I know that's a mouthful. We call it NCA4C for short. And Sarah Arthur is here. She is our new director within the state for A4C, and she's going to give you an overview of what A4C does for the state of North Carolina. She is the program manager for comprehensive cancer control for the state of North Carolina. Sarah.
Yes, thank you, Dr. Paterno. And Dr. Paterno is one of our co-chairs for the advisory committee. He's our head chair currently, and we're very grateful for all the work he has done. He's been staying on longer than his appointment term, just because of a lot of turnover, but we're very, very appreciative of him. So as Dr. Paterno was stating, the advisory committee or the advisory committee on cancer coordination and control, we refer to it as the A4C, or the advisory committee for short. We are a statewide advisory board, and our mission is to facilitate the reduction of cancer incidence and mortality for all North Carolinians, enhance a statewide access to quality treatment and support services, and maximize the quality of life for all North Carolina survivors, patients, and their loved ones through educating and advising government officials, policymakers, the public and private organizations, and the general public. This advisory committee is composed of 34 legislatively appointed members. Next slide, please. So those members they represent a wide variety of appointments. So they can be survivors, cancer survivors, legislators, physicians, healthcare professionals, and other cancer advocates. And they're appointed either by the governor, the North Carolina Senate, or the North Carolina House of Representatives. We also have over 100 partners that help guide the board as well. And we have 2 of our appointed members on this call today that you heard from Dr. Paterno, who's one of our appointed members, and you'll hear shortly from Dr. Ronnie Bell, who is another one of our appointed members. Next slide, please. So this board or committee is in charge, tasked with creating the North Carolina Comprehensive Control Action Plan. This is a statewide blueprint for action. It to reduce the burden of cancer, identifies cancer challenges and issues that affect North Carolinians. The cancer plan offers goals and strategic actions supported by the evidence-based interventions and current cancer information. And it covers the entire cancer spectrum from prevention all the way to survivorship. Next slide, please. So our current action plan is broken out into 3 components: your priority action priorities, priority cancers, and your call to action. The action priority section has information on cancer risk factors and healthy behaviors, policies, environmental changes that can reduce a North Carolinian's risk. The priority cancer section emphasizes the 6 priority cancers, which were selected because they are preventable through screening and HPV vaccination. Our 6 priority cancers that we really focus on are lung, female breast, colorectal, prostate, cervical, melanoma, and non-melanoma skin cancer. And as Dr. Paterno stated earlier, a lot of the work we do through the advisory is related to tobacco as well, because if you notice, the 6 priority cancers all have that link to tobacco. By tobacco prevention, you can lower your risk of cancers. And then lastly, we have our call to action. Next slide, please. So what is the purpose of having a plan if we don't have anything actionable? So that's why we created the strategic action plans within our plan. And so within that, we include evidence-based strategies and actions that businesses, schools, and individuals, community organizations, or healthcare professionals can take to help reduce the burden of cancer. And these are broken out through those cancer continuum components. So we have our prevention section, early detection, and our survivorship section. And this is just a little snapshot of one of the strategic actions with a task that you could do as either an individual or, like I said, individual, school, business for you to do. Next slide, please. And then lastly, we continue to evolve and make sure that we're doing everything equitably. So we have a specific section within the cancer plan that talks about health equity. And we know this is also very much of importance, especially when we're talking about tobacco, because there's very specific populations that are more affected than others. So we continue to evolve and making sure that all of our work has that health equity component throughout. Next slide, please. And then lastly, again, this is another just example of our cancer plan. So again, it's broken out into those 3 main components. Cancer prevention is one of the main ones. And as you can see, a big focus of prevention is tobacco use. And you'll hear a little bit more of how that is a big focus within our advisory committee subcommittees. So the subcommittees, we have 4 subcommittees, and that's prevention, early detection, care and treatment, and legislative. And the prevention subcommittee has 3 work groups, and those work groups are very much in alignment with the cancer prevention section. So you'll see we have a work group specifically on tobacco. Next slide, please. Oh, yes, and then do you want me to go ahead and introduce Dr. Bell?
Well, thank you first and foremost, Sarah, for sharing that information. We really appreciate all the work that you do with the Cancer Control Branch, as well as with A4C across all the different committees. I would be remiss if I did not say Dr. Bell and myself are extremely thankful and appreciative for you and all the work that you do for the Prevention Committee. And so if you would like to introduce Dr. Bell, by all means.
Certainly, and thank you very much for that. So Dr. Bell is one of our prevention subcommittee co-chairs, along with Kirsten. He is the governor appointed member of the advisory committee as a whole as well. He is associate director of community outreach and engagement and the director of the Office of Cancer Health Equity at Wake Forest Comprehensive Cancer Center of Atrium Health, Wake Forest Baptist.
Thank you, Sarah, and thank you, Kirsten, and thank you all for joining us today. This is a really great opportunity for us to make a significant impact in the lives of many of our citizens here in North Carolina. So thank you for being a part of this. So I'm going to talk about the North Carolina A4C Prevention Subcommittee, which I have the good fortune of co-chairing with Kirsten, and Sarah, as you heard, is a great component of the work and helping us really operationalize some of the components of the elements of the state Cancer Control Action Plan. So next slide. Go ahead. So this is what we do is try to put together a strategy, try to help sort of coordinate the efforts of our subcommittee. You can see that we have really in 2021 and 2022, we had our major focus areas of lung cancer, cervical cancer, and HPV related cancers, and behavioral risk factors and obesity. And I don't have time to read through all of those areas, but we did develop these initiatives trying to focus on specific areas. And again, keeping in mind that our focus is on prevention, but we do work with the other subcommittees and particularly the early detection committee. So for lung cancer, we focus on sort of the major risk factors for lung cancer, and for cervical cancer, we have a focus on enhancing evidence-based strategies for increasing HPV vaccinations, and then for behavioral risk factors, working on factors related to obesity prevention, healthy eating, increasing physical activity. Next slide. And so so you can see this more clearly. This is the our purpose is to provide guidance to impact healthy behaviors through promotion and education, policies, and environmental changes to reduce cancer risk for citizens of North Carolina. Our vision is to provide education and promote policy, system change, and evidence-based interventions to reduce cancer risk factors. And our current priority areas are relevant to our work discussions today: tobacco, environmental exposures, and behavioral risk factors. And as Sarah mentioned, as is the case for the work of the Cancer Prevention and Control Branch, our prevention subcommittee is really trying to consider our priority areas as it relates to issues around health equity. We have a very diverse population here in North Carolina. We have the largest American Indian population in the eastern United States. We have a growing Hispanic population. We have, particularly in the eastern part of the state, a very large African American population. We have North Carolina has one of the largest numbers of people living in rural communities. 80 of our 100 counties are designated as rural. And so we really want to try to ensure that the strategies that we promote are evidence-based, but also that they are considered with a health equity lens. Next slide. And so these are just some of the resources that we have developed over the years and helped promote. So the lung cancer toolkit for healthcare providers, the Live Healthy to Be There action plan to promote healthy eating and physical activity, and then working with the state radon program to increase awareness of checking your homes for radon exposure and going through the mitigation strategies if your home does have high radon levels. So this is the radon fact sheet that was developed in collaboration with Philip Gibson and the North Carolina Radon Program. Next slide. All right, so I will turn it over then to Megan, who is the tobacco treatment specialist with the Duke Smoking Cessation Program, to go through the actual training.
Great, thank you. I'm actually going to introduce Megan. My name is Jill Dirks. I'm the program manager of the Duke Smoking Cessation Program. And when I think tobacco use treatment cancer patients, I really think about Megan. Megan is very much an expert in this, so I'm excited to have her here for this training, and really excited to learn from you, Megan, about this. A couple of quick housekeeping items. So for those of you who intend to who intend to claim education credit for this, please just make sure that your name in Zoom reflects the name you want to receive continuing education credit. It should also be the name that you registered for as well. If you need to change that, you just hover over your picture or your name, you just click the 3 dots and change your name to your first name so that we can match that up with our records on the back end. But that is recorded automatically. If you have questions during the training, please go ahead and put them in the chat. I'm going to be jumping in and helping Megan and to answer those. So a couple of additional things about Megan that I'll just share with y'all. She's a licensed clinical social worker. She has been here since 2018 and was really an integral part of the team to start services at the Duke Cancer Institute. So to get specialized tobacco treatment to cancer patients and survivors. She helped us expand services at the Duke Cancer Center, and in the first year that she was here, helped us open services at the Duke Raleigh Cancer Center. Megan leads groups and individual sessions focusing on tobacco use treatment, and she does that by telehealth and in person. She is also a faculty member with the Duke UNC Tobacco Treatment Specialist Training Program, leading sessions on motivational interviewing, behavioral treatments, and health equity. Welcome, Megan, and thank you so much for this presentation on such an important and timely topic.
Thank you so much, Jill, and thank you everyone for being here. I'm very excited to share with you all on this topic. It's very near and dear to my heart, so appreciate the opportunity. Next slide. So we do have a few learning objectives for the training today. First being to describe tobacco use rates in North Carolina and specifically in the cancer population. To identify the causal relationship between continued tobacco use and cancer risk recurrence and worsen cancer treatment outcomes, describe effective methods of tobacco use treatment, and then to summarize, ask, advise, refer model to engage patients in tobacco use treatment, including using a validated question to assess tobacco use. And we'll see the importance of that question as we go through the training. Next slide. So I wanted to start off today with just a few statistics about tobacco use. So if you look at this, this graphic here in the black with the yellow arrow on it, smoking in the US has declined pretty dramatically from 1965 until this graph only goes up to 2009. But we do see this sharp decrease in tobacco use. Right now, that number, and again, these are not the most up-to-date numbers, but they're the most up-to-date numbers that we have. In the US, 17.8% of the population smokes. This does not include vaping. This is combustible tobacco use. And in North Carolina, that number is a little bit higher. We're still at 20.3% here. And also want to note that 67% of current smokers will die from an illness caused by smoking. So it's really important that we offer patients who are smoking evidence-based treatment that works to help them quit, because that's going to be one of the most important things that they can do for their health. If you look on the other graphic, almost 500,000 people die every year from smoking cigarettes. So that's a huge number of people that, those are preventable, potentially deaths. These are health problems that can be greatly reduced or alleviated by quitting smoking. So one of the challenges is that an average smoker has over 7 unsuccessful quit attempts before they're able to quit for good. So quitting smoking, not only is it very difficult because of nicotine dependence, but it can be really stressful, really demoralizing if you've tried to quit multiple times and not been successful. So when we're talking with patients about their tobacco use and specifically offering them treatment options, we want to reassure our patients that what we're offering them is really successful. So we're giving them the best chance of being able to quit for good with this treatment that we are referring them to or offering to them. Next slide. So just wanted to touch on some of the different types of cancer that are firmly linked to tobacco use. The ones that most people are familiar with, we have lung cancer, of course. People highly associate lung cancer with smoking, but there are 12 different types of cancer that are linked to smoking. Can you go back, Kirsten? Sorry. Okay, thank you. People are really familiar with lung cancer, mouth cancer, esophageal cancer as being linked to smoking, but less often people realize that breast cancer, uterine cancer, stomach cancer, colon cancer, cervical cancer, bladder cancer, people don't realize that these other types of cancer can also be linked to smoking. So if you're working with patients outside of the lung cancer population, it's really important to make sure that they understand that smoking affects all of their organ systems. It's affecting their whole body. And so there are many different forms of cancer that can be linked to smoking. So just because they have a clear lung cancer screening doesn't mean that smoking is not affecting their body and isn't potentially contributing to a cancer diagnosis. So we're not here to scare our patients, obviously. What we really want them to know is that your risk is reduced after you quit smoking. So your risk for developing a primary cancer and your risk for cancer recurrence if you already have cancer. Next slide. So again, as I was mentioning, why should your patients quit smoking? It's really important that patients quit smoking for many reasons after a cancer diagnosis. So as I mentioned, reduced risk of recurrence at the same primary cancer location, as well as reduced risk of a second primary cancer. But there are also good reasons to quit if you are getting cancer treatment. So for surgery, we have reduced post-surgical complications, infections. Smoking at surgery time can impair wound healing. So a lot of our surgeons are very reluctant to perform any type of surgery on people who are smoking if the surgery can wait. So reconstruction is a big area where surgeons want people to be completely free of nicotine before they do that surgery, because the healing is very important for reconstruction, and the surgeons want to give their patients the best chance of a good result that they can. So quitting smoking is often a requirement. Chemotherapy and radiation, the risk of side effects and complications are reduced when people stop smoking. So despite these compelling reasons to quit, 64% of people with a cancer diagnosis continue to smoke. So those are the folks that we really want to engage and talk to, as well as those who do not have a cancer diagnosis. But specifically, most of the professionals here are working with people who are at least in screening or they have a diagnosis. So that's who we want to capture, the people who are still smoking, to get them quit for all of the reasons listed here. Next slide. So people who smoke have a lot of challenges when it comes to quitting. A lot of people who smoke use smoking as a coping strategy for stress, anxiety, depression, and these challenges are big predictors of relapse. For a lot of people, especially if they have a cancer diagnosis, it is one of the most stressful times in their life. They have a lot of appointments, they're worried about their health, their mortality, worried about potentially loss of income. And so the level of stress, anxiety, and depression can be very high. At the same time, we are encouraging people who are the most stressed they've been, maybe ever, to give up one of their primary coping strategies. And so if we're asking that of our patients, and if the patient wants to take that step, again, we want to offer them the largest amount of support that there is. We really want to wrap patients up in as much support, as many services to meet their needs as we can, and offer them comprehensive services. So a lot of people, again, another barrier that they have is that they want to quit, but there is a cost barrier. So these medications to quit smoking can be expensive. So we also want to be familiar with resources that are available, lower cost alternatives for our patients. Was there a question, Jill?
Yeah, there's a good question in the chat. Does vaping also put you at risk of cancer as cigarettes do? I have members who quit smoking cigarettes but now use a vape. Are the risks the same?
That is an excellent question, and unfortunately, I don't have an excellent answer. So when it comes to vaping, what we know based on the research is that smoking is firmly linked to the cancers, as I mentioned in a previous slide. Vaping is much newer than smoking, so we have decades of research on smoking that has linked it to all the cancers that were mentioned in that previous graphic. Vaping may be safer than smoking. You know, on the face of it, it seems like it may be. We do not have the research to say for sure how safe vaping is, especially when it is not nearly as regulated as smoking. So a lot of the injuries coming from vaping that we do hear about in the news are linked to these unregulated products. So, you know, as far as vaping, unfortunately, I can't give a clear-cut answer, but for someone who wants to stop using nicotine, to stop smoking, using FDA-approved medications to fully stop and get off of nicotine altogether is the way to go. Often if people switch to a vape, then they switch to a vape, right? People sometimes will switch to a vape to help them stop smoking, and then the end result is now they vape. So again, you know, I want to be clear that I'm not saying that vaping is as dangerous as smoking, and I'm not saying that it isn't. I'm saying the research isn't there to say for sure one way or the other. Ask me in 50 years. Next slide, please. Okay, so what we want to talk about today is the Ask, Advise, Refer model. So this model is a really succinct, quick way that is easy to remember when you're talking to a lot of patients, you're interacting with people briefly. You can ask about their tobacco use. And we do want to identify and document tobacco use status every patient, every visit. This is something that can change from visit to visit, depending on patient situation. So we want to make sure that this information is up to date. So ask is very important and is usually, at least at the medical appointments that I've attended, asking about tobacco was a part of the visit. It was a part of the vital process, the check-in process by the nurse or the medical assistant. So we want to make sure that's happening. And then the next step is to advise. So we are advising our patients to stop using tobacco. You're going to give them a clear, strong, personalized statement advising them to stop. And personalized is very important here. This is why knowing your patient's situation is important, because you want to be able to tell the patient, you in particular should stop smoking because you're starting chemotherapy and smoking creates a greater risk for chemotherapy side effects. You know, that is what we're looking for as far as the advise portion. And then the last and arguably most important part of this whole process is to refer the patient to a resource that offers comprehensive tobacco use treatment services. And a lot of times where we see a disconnect is between this advise and refer step, because this is where the patient can decline the referral. So we're going to talk a little bit later about strategies you can use to try and encourage your patient to accept the referral and to move forward with tobacco treatment. Next slide. Yes.
Megan, a question is that maybe you will address here, but is secondhand tobacco use exposure included in patients' visit documentation?
So it depends. Rarely, I would say. Sometimes it can be, but it is usually not. So I'm going to show some in a couple of, I think the next slide, I'm going to show a screenshot from Epic, but usually secondhand exposure is not included, but it may be included in like the narrative section of the patient's history, but good question, and typically not. Okay, so how do you ask about tobacco use? This is a really important point of this whole process. And again, I've said each step was the most important. They're all important. They're equally important. But how you ask is going to really determine the quality of the answer that you receive. So the way we want to ask is in an open-ended and non-judgmental way. So a very excellent way to ask is, can you tell me about your tobacco use? If the patient doesn't smoke, they've never smoked, they can say, I don't smoke, I've never smoked. Great, we'll check that off. For someone who is listed as a former smoker, again, great way to ask, when was the last time you used tobacco? So some of the ways that this question can go wrong, and this has happened to me, it's probably happened to many people in this room if you are listed as a non-smoker in your medical chart or a former smoker. The person who is doing your check-in for your medical visit is going through their checklist, right? They have a set assessment, they have set questions they're asking about your medications, and they get to tobacco. You don't smoke, right? I've been asked that many, many times. Very common to ask that way if they're listed as a non-smoker. The problem with that closed-ended yes or no question is that it's very easy to say no to that question, especially for people who are occasional smokers. So for someone who is calling themselves a social smoker, or for someone who has cigars on the weekend, they are very likely to say no if you ask them about, you're not a smoker, right? No, I'm not a smoker. Because if they don't identify with the title of smoker, then they're going to say no to that. So we really want to give the patients the opportunity to give a nuanced answer if they need to. Well, I chew tobacco and I smoke cigars on the weekends with my friends, but I don't do it every day. Okay, great. I'm going to list that in your chart. And that's another good point. What I just said is that I've done it in this presentation many times already. If anyone has noticed, is talking about smoking. Smoking is not the only way to use tobacco. So we don't want to forget our other patients who are using other forms of tobacco. So in this presentation, I say smoking a lot because overwhelmingly that is the form of tobacco being used by the people that I work with on a daily basis. But I've worked with people who chew tobacco. I've worked with people who dip. I've worked with people who smoke pipes and cigars. So again, we just want to be really intentional with how we're asking these questions to make sure we're getting the appropriate answer from our patient and make sure that we are able to offer them the support that they need because we have the information that we need to offer that support. Next slide. Okay, so this is a really good opportunity when you're asking these questions. If you are the nurse, the medical assistant, you're working as a navigator and you are in the patient's chart documenting, this is a really great opportunity to update their tobacco history. I've got these screen captures from the Duke version of Epic. So if you're in a setting that uses an electronic medical record other than Epic, it may look different than this. Your Epic may look different than this because the Epic system is personalized for each institution. So it may not look like this, but the idea is be familiar with how your organization is documenting tobacco use and make sure you are regularly updating that for your patients and at least checking to make sure that it's accurate. In our particular version of EPIC, as I mentioned, tobacco use is listed under substance and sexual activity, but e-cigarette use is listed separately in its own category. So again, knowing those little nuances to your system is very helpful to make sure you are able to list the information appropriately. So again, on ours, it gives you information about their smoking status, start date, quit date, what they use, how many packs, and it will calculate their pack years for you. It also has smokeless tobacco listed. So, making sure that you are checking this information for patients before you meet with them to see if they are listed as using any tobacco products helps prepare you for your meeting with them. Next slide. So that brings us to the advise portion. As I mentioned before, we want to be very clear with the patients that we are advising them to stop using tobacco. Some examples: one of the best things you can do as part of your cancer treatment is to stop using tobacco. Quitting smoking can help you recover more quickly from your upcoming surgery. It can be hard to make a change. I will connect you with a dedicated team that can help. I'll refer you to a program that offers the most effective treatments available, behavioral counseling and medication together. So we are going to provide to the patient a very clear advice. You should stop using tobacco. And as we are doing that, we are very likely to hear some pushback from the patient. Next slide. So one of the techniques that you can use, and again, I'm bringing up motivational interviewing. I just want to be clear here. I understand that medical visits in particular are brief, and you may not have a lot of time to talk with your patient. So what the strategies that I'm bringing up are very brief strategies that you can use. Motivational interviewing is a technique that is extremely helpful. It's used extensively in substance use treatment. Really great technique. So if you like what we're talking about today, and this is the first time you've ever been introduced to any motivational interviewing, and you would like to learn more about this, there are many excellent trainings about motivational interviewing. Motivational interviewing, as I said, as Jill mentioned earlier, is included in the tobacco treatment specialist training that is offered by Duke and UNC. So there are opportunities. If you get this brief snippet that we talk about today, you want more information, please, get additional training into motivational interviewing, because it is an extremely helpful technique, especially when you're dealing with subjects that are difficult and that patients may be less excited about, and changes they're less excited about making. So motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation to change. Motivational interviewing helps to address ambivalence and create discrepancy, as well as identifies readiness, willingness, and ability to change. So motivational interviewing is all about being collaborative with your patient and helping them identify their goals and whether their current behavior is helping them to achieve those goals. So what you're really trying to do is pull out, okay, the patient is saying that they would like to stop smoking, but they're too busy right now. Okay, so you would like to stop if you had the time. Can we talk about some options that might fit into your current schedule? That's what we're looking at for motivational interviewing. Next slide. So when we're talking about motivational interviewing, there are some guiding principles that are part of this. So I gave a very brief example of a motivational interviewing aligned way to talk to your patient if they have an objection to a smoking cessation referral. So how you get there is by following these guiding principles of motivational interviewing. First one is to resist the writing reflex. Healthcare providers have a tendency to advise patients on the correct action for good health. And so you're saying, okay, Megan, the name of this section is advise. I'm supposed to be advising the patient. That's correct. But we want to advise the patient in a way that is going to help them feel confident, help them feel in control. Not that we are just telling them you have to stop smoking and shaming them about their smoking. It's very common for patients to be shamed about their smoking, especially if they have cancer, not even intentionally, but maybe intentionally from their families, but their health providers are probably already on their case about smoking. So what we want to do is to kind of resist that reflex, pull back a little bit, have some space in the conversation. And again, this is where I can acknowledge you don't always have time to get into a very in-depth conversation with your patient about their smoking, about their treatment. But if you have an extra 10 minutes, you can have this conversation. If you have an extra 5 minutes, you can start a conversation. You can plant a seed. And that's really what we're going for here. So you want to resist the writing reflex, as I said. And then the next step is to understand the patient's motivations. So the patient's own reasons for change are more impactful than the provider's reasons for the patient to change. Even if the provider's reason is, if you don't stop smoking, you are going to die, the patient may not feel a connection to that reason, or they might feel defensive about that reason or not ready to deal with that reality. But their reason for change might be, I'm not allowed to smoke in my apartment. And that in itself might be more impactful than the doctor saying, if you don't quit, you're going to die. So we need to have the time and the space, if possible, to hear the patient's reasons. Are you interested in quitting? What are some of your reasons that you might want to quit, or you might consider making a change to your smoking? And listen with empathy. Try to spend equal amounts of time listening as well as talking. Patients feeling heard is very important when you're asking something very difficult of them. And along with that, empowering the patient. So a patient feeling like they are in control of some aspect of their treatment journey is crucial. A lot of times I will hear people tell me that smoking is all they have left. They've given up drinking, they've given up fatty foods, they've given up, lots of things, but they're not ready to give up smoking. And so as you're working with a patient in that situation, you want to help them see that they may have some reasons for changing their smoking behavior too. And you want to talk them through that as you have time. And like I said, this can be very brief. You can do all of these things briefly. You can empower your patient, tell them, we have programs that can help you if you are interested, and then having them move forward with that. So, like we talked about, the patient may tell you, I have too many appointments right now. I can't come to this cancer center and park and pay for parking for another appointment every week. So a great response to that using the motivational interviewing principles is, if there were options that would not require you to come in for an appointment, would you be interested in hearing about them? Patient may say yes. Then you can say, well, we have a program here at our institution that offers telehealth visits, or I can refer you to the North Carolina Quit Line, which offers telephone-based coaching. And a patient may be much more open to that when you've addressed their concern. Okay, you have too many appointments. I get it. I hear you. It's a lot. We can offer you something that meets your needs. Do you want to hear about it? And they can say yes or no. So that's really what we're looking at with the motivational interviewing side, is just to come alongside the patient, to be a collaborator with them and try to pull out any change talk that they're making. So, oh, I've tried to quit and it didn't work. Oh, can you tell me about what you've tried before? Well, I tried cold turkey and I was smoking again the next day. Okay. Would you like to hear about other options that are available as far as like medication and counseling? That's what we can offer to you if you want to hear more about it. And again, the patient is in control. They can say yes or no, but we want them to understand that there are options available. So again, very brief on motivational interviewing, but it's a really great skill to develop. And I see the question. Yes, I will, Nancy. So we'll get to that in just a second. We're going to be talking more about treatment. Next slide. Okay, so as part of our refer process, so we've asked the patient if they smoke, they say yes. We've advised the patient that they should quit, and they say, okay, what can I do? What are the options? So I have ranked some of the treatment options that are available in kind of rank them by most intensive to least intensive order. So the treatment options that are available, I've listed out our comprehensive cancer centers in this area. So we see here Duke, UNC, Wake Forest Baptist, and WakeMed is not one of our comprehensive cancer centers, but they do have a smoking cessation program. And I've listed these hospitals because these are the ones that are in the Triangle area. I know that there are people on this call who are from different places. So you may need to do a quick search of your area to see what comprehensive smoking cessation programs are available. Your comprehensive cancer centers should have some smoking cessation resources, and many large hospital systems will have smoking cessation programs. So in this area, we've got several excellent ones. I'm most familiar with Duke, obviously, because that's where I work, but I know people at each of these programs at Duke, UNC, Wake Forest Baptist, and WakeMed. So, all of these are options for your patients, and that's where they're going to get, likely going to get the most intensive treatment options. Next option for patients, they say, I don't really want to go in for more appointments. Is there something I can do on the phone? And the hospital affiliated or cancer center affiliated programs may or may not have a phone-based option, but Quitline NC is a phone-based service. So this phone number, 1-800-QUIT-NOW, is going to connect you with a Quitline local to you wherever you are in the US. So if you call this number, it's going to link you with a Quitline service. So here in North Carolina, the Quitline provides telephone or web-based coaching and nicotine replacement therapy for patients who are ready to quit. Now, these Quitline services, their offerings as far as nicotine replacement and frequency of calls, number of calls, what they offer is going to be dependent on the Quitline itself. So where you are is going to sort of determine what they offer, but you are going to be able to get telephone or web-based coaching, often can get NRT. Sometimes it does run out throughout the year. So just make sure patients are aware of that. But Quitline NC is a great option for people who need a phone-based service. Next slide. And then some other treatment options, again, these are going down in level of comprehensiveness and level of engagement with a real person. So the next options are some quit smoking apps. Smokefree.gov offers a couple of different apps, Quit Guide and Quit Start. And there's also a popular app, at least on the Apple App Store, called Smoke Free App, and this is developed in London and is not affiliated with smokefree.gov. The apps are, again, less intensive than a program where the patient would be talking to a person, but they may be able to this may be a good adjunct for someone who is just looking for some check-ins, something that they can do that's self-guided, and who already engages a lot with technology. So that's the kind of person who might find an app helpful. But again, they're not as intensive, and the patient may not get a huge amount of benefit from it, but it's better than no support whatsoever. And then there's a smoke-free text, which is a text messaging program that the patient can work with. Yes, Jill.
Yeah, there's a question in the chat. Do you have any recommendations for treatment services in Spanish?
Yes. So Quitline NC does offer many different languages, and Quit at Duke offers services in Spanish. We have providers who are fluent in Spanish, and we also we can use translation service for many different languages, but if the patient wants to see a provider who speaks Spanish, we do have that available at Quit at Duke.
And another question, do tobacco treatment specialists advocate with pharmacists, doctors, or other healthcare providers to communicate with tobacco cessation treatments or medications? And does Duke try sublingual pills or a confidential SMS system to support those who would like to quit?
Yes. So our program at Duke, and I'm going to talk about how our program is set up, which is a little bit different than some other programs, but we have specific providers, medical providers and behavioral providers who are doing the smoking cessation treatment. So our medical providers would be the ones communicating with your medical team primarily. And they do communicate with your medical team to make sure that your medical team is on board with whatever treatment we're talking about. And, in other settings, tobacco treatment specialists are also working closely with that medical team to make sure everyone's on the same page and everyone's in agreement that the treatment being offered for smoking is going to work for the patient. So next slide.
One
Yes.
last question, Megan. Are there any other resources you didn't mention that are resources for patients that speak Mandarin?
So as far as, like I said, a patient who speaks Mandarin can get services through at least Quit at Duke and likely the other hospital services through translation services. So that is going to require a little bit of coordination, likely going to require coordination. I'm not sure about Mandarin for Quitline. I know they have a number of different options that they offer, but I'm not sure about Mandarin. Do you know offhand, Jill?
I believe they do.
Okay.
I know they have Spanish speaking folks, and I think with Mandarin they use translators or interpreters.
Okay. Great. So, interpreters are probably going to be the option for a lot of different languages, ASL being one that we also use interpreters for. But that being said, there are options. They may not be as ideal as speaking one-on-one with a person who is using the same language as you. Using an interpreter is not everyone's favorite thing to do, but it can get the service to the person who needs it. So, yeah. Okay. So moving back into the refer portion. So I'm going to talk a little bit more about Quit at Duke and our program. And again, all of the programs are going to be a little bit different. So this information is specific to Quit at Duke, but it gives you an idea of what a patient can expect from a smoking cessation program, but may not be exactly the same for all the different programs that are available. So Quit at Duke offers evidence-based intensive tobacco cessation, as well as referrals to low-cost options for patients, and we do help people kind of navigate that. We have a couple of outreach specialists who are working with our patients from that first point of referral to help them determine, okay, what's going to be the best fit for you? Are you going to be able to access the services that we offer? Do we need to refer you to the Quit line? That sort of thing. So we offer services through telehealth, and we have some in-person services as well. A lot of our patients, particularly cancer patients, really prefer to do the telehealth because of the number of appointments that they have, concerns about infectious disease risk, especially right now with flu and COVID being really, really present in our community. A lot of people with suppressed immune systems are staying at home as much as they can. So telehealth has really been wonderful for our cancer patients. And again, we do offer specialized services for patients with cancer. So myself and a couple of our other providers work primarily with cancer patients. And we have sort of specialized services there with our own providers for those patients experiencing cancer or being screened for cancer. Next slide. So what is different about the Quit at Duke program that helps us improve outcomes? The first is our comprehensive evaluation. Second is evidence-based medications, targeted behavioral treatment that's very intensive, and then long-term phone-based follow-up. Next slide. When we are evaluating our patients for their first appointment, so with the Quit at Duke program, often when a patient has their first appointment scheduled, it's going to be with one of our medical providers. So PA, nurse practitioner, medical doctor. And that evaluation is going to be more of a medical evaluation to determine, any underlying health concerns, any underlying mental health concerns, substance use, concerns about weight gain, any financial challenges, their level of support, their level of dependence. We are doing a really comprehensive evaluation on the medical side for that first appointment to then determine the patient's treatment plan moving forward. So we're getting a really good idea of the patient's situation, what they've tried before, how long they've been smoking, and then we are tailoring their treatment plan based on that evaluation. So they may be referred to behavioral treatment. They may be prescribed medications. That's going to be determined in that initial evaluation. Next slide. So medications, the medications that are primarily used for smoking cessation, our first line treatments are either varenicline, also known as Chantix. So you'll hear me say varenicline, but just know that you may be better known as Chantix. And then that is one first line option. Other first line option would be combination nicotine replacement therapy. Combination meaning it's a nicotine patch, which is a extended release medication, along with an immediate release nicotine product, such as nicotine gum, nicotine lozenge, nicotine nasal spray, nicotine inhaler, something like that. So, yes,
question,
Jill.
Megan. Do your patients use NRT during their ongoing chemotherapy treatment?
Yes, most of the time they do. If they're using NRT. So there can be reasons that a patient wouldn't use NRT that is going to be determined by their medical visit and our provider's conversation with their medical team. A lot of times when patients are going to have surgery, there may be some restrictions on nicotine. So not just on smoking, but on nicotine as a whole. And so that is a reason that a patient might not remain on nicotine replacement. And like I said, that's something that they determine in combination with their medical provider in the smoking program, along with their oncology team, their surgical team, whoever else they're working with for their medical treatment. So the other medication that is frequently used for smoking cessation is bupropion, also known as Zyban or Wellbutrin. And that is not a first-line treatment. So that medication is often added to one of our first-line treatments. So either our varenicline or our combination NRT. Bupropion is sometimes used by itself, but it doesn't work as well as the other two. So it works better when it is combined with another medication. So the next thing I wanted to mention, so I see the question there. So drug interaction, this is why we have our medical team working with the patient's medical team and oncology team. The question is drug interaction a constant challenge while using Chantix or bupropion along with cancer drugs? So it's more of a challenge with the bupropion than it is with varenicline. And that is something, again, bupropion has more drug interactions and it has more contraindications than varenicline does. But this is our medical providers are reviewing the patient's chart. They are working with the medical team to determine whether a treatment is going to be safe for that patient. And we're balancing, what is reasonable and effective treatment for the patient along with what is safe, and wouldn't recommend anything that wasn't safe for the patients, of course. Now, pre-quit treatment is another large part of our treatment model. So if you look at the box of varenicline, it's going to say to take the medication for a week and then to stop smoking. And for some people, that method works for them. But for the vast majority of people, especially if they have high levels of dependence and they have been smoking for a long time or using tobacco for a long time, they need more than that. So we have them using the medication for a longer period of time prior to quitting. And, 4 weeks is pretty standard. Some patients are a little longer than that because people determine their own quit dates for the most part in our program. But we are doing it longer than a week, if at all possible. And sometimes it's not because of surgery and things like that, but we want people to have the best chance of quitting that they possibly can. We're also using adaptive pharmacotherapy. So what that means is that our providers are meeting with the patients on an ongoing basis and assessing and adjusting their treatment as needed. So let's say a patient is using combination NRT and they're not getting enough treatment response. So they've cut down a little bit, but they don't feel like it's really working very well for them. We may add on bupropion to that patient's treatment to see if they can get a better treatment response for that. And often they do. So we have our providers meeting with the patients frequently to make sure that they are getting the full support and the best treatment that they can, that their treatment is working, and that nothing has changed that then would need to alter their treatment. And then the last point is this idea of extended treatment. So we're looking at 6 months of nicotine replacement therapy versus the standard of 12 weeks, and that seems to keep people quit and to help them. Seems to be a better treatment outcome from the 6 months versus 12 weeks. Next slide.
That's a good
Yes.
question as well. Is bupropion safe for long use until complete cessation?
So again, your medical team is going to determine, the patient's medical team is going to determine what's safe for them. But typically, bupropion is safe for the patient. If it's safe for them to use, it's safe for them to use for the duration of their their quit and their complete cessation, unless something changes with their medical history in the interim. But usually the medications that we put the patient on are used throughout until they're completely quit, and then typically for about 3 months after they quit. All right, so for our behavioral treatment, we do here at Quit at Duke offer intensive group therapy. We have a mindfulness training for smokers group. That's an 8-week group intervention. The group lasts for 2 hours each meeting, and there's a built-in quit date. So everybody in the group quits together on the same day. The group is very effective and is very much well loved by our patients. They find that the support from the group is very very helpful to them on their quit journey. And mindfulness is the most effective behavioral treatment for smoking cessation. So for patients who really connect with mindfulness and connect with the group setting, great intervention. One of my favorite things to do. I love it. And then we also offer individual therapy. I meet with patients on a one-on-one basis, and usually they're meeting somewhere between 6 and 8 sessions, sometimes more. But we do offer that, and web-based treatment is sometimes a part of that as well. Next slide. All right, so for anybody that would like to make a referral to the Quit at Duke program, patients can self-refer to the program or be easily referred by a Duke provider if they are a Duke patient. And for a patient who wants to self-refer, or if you as a navigator or in your other professional life would like to refer a patient, simply call 919-613-QUIT or 919-613-7848 to speak with one of our wonderful outreach specialists who are, they have completed the tobacco treatment specialist training. So these are highly professional staff members. It's not a call center that they're calling. This is our personal staff members who will be answering the phone at this number and are highly trained in talking with patients who are using tobacco. So you can feel confident if you do refer a patient that they will be spoken to and handled appropriately throughout the process. Next slide. And here I just have, again, the contact information along with my email address. I'm happy to talk through any questions with anybody or tell people more about the program as we go along. But that is all I have. So I know we had some questions that I did not answer yet, so I'm happy to address those now.
Yeah, so a good question. Some patients raise the question of getting addicted to these medications, especially when we talk about 6 months. What are your thoughts about that?
Yeah, so that's a really good question. And I have patients all the time who are concerned about getting addicted to the meds, which is a valid concern, of course. The thing about the nicotine replacement therapy in particular is that it is a lower and slower peak of nicotine than what a patient gets from smoking a cigarette, for instance. So if you're wearing, for instance, the nicotine patch, that's going to be an extended release of nicotine. It keeps you steady through the day. And then you're going to get a little spike of nicotine from nicotine gum, nicotine lozenge, nasal spray, whatever your immediate release is. So what happens with that is the payoff is not as great from using these products as it is from smoking. So they're not reinforced in the same way. You're not getting that quick hit of nicotine that really drives up that level sky high and drives this nicotine addiction cycle. So the idea of the nicotine replacement products is they really sort of take the edge off of urges and cravings. They're not going to totally satisfy in the same way that smoking does. So they tend to not be as addictive. certainly not as addictive as smoking. Some people do get something like a behavioral reliance on like the nicotine gum or the nicotine lozenge, but not a true like addiction to the nicotine in the product. Any other questions?
Yeah, there's one question which is actually a good follow-up to that. I've seen
Mhm.
studies that show increased growth of cancer with nicotine use. Are you worried about that?
So when we're using nicotine products for smoking cessation, I'm much more worried about a person continuing to smoke. So, I would rather a person use the nicotine product short term to help them quit smoking and then come off of the products. And that might be, depending on the person's situation, the amount of time that they're going to stay on the product is going to be dependent on that. So as far as, specific studies, I'm not a doctor, so I'm not going to speak to specific studies about cancer cell growth with nicotine. I'm not knowledgeable enough to speak to that. But I will say that my priority is to help people get off of cigarettes, which we know are substantially linked to cancer, different cancers, and cancer recurrence.
Fantastic. Thank you, Megan, and everyone for the amazing and informative conversation, discussion, and training. We are not done yet. We do have a few words, and we will, after our guest says a few words, we will be more than happy to share a couple more questions with the team. But we have on the line Mr. Christopher Draft. He is an international lung cancer advocate. He served on the NFL for 12 years as a linebacker. He was with the Carolina Panthers, not Patriots, Carolina Panthers. Oh my goodness, messed up the states there for a second. But just wanted to give him a few moments to share a few words in regards to the work that he does. He also serves as a board member for the White Women Project. And he has been doing a lot of work really in increasing awareness around lung cancer awareness and work in sharing how important patients are as they're going through their cancer journey. So without further ado, I am going to turn the mic over to Mr. Graff.
Thank you for the introduction. And, you can see I'm in the car. I've got my seatbelt on. So I just left Wake Forest Cancer Center. We had an opportunity to present some ribbons to some of their thoracic team. So we presented some of our White Ribbon Project ribbons in appreciation for the work that they're doing. I know there's a number of people in terms of some of the panelists and speakers that we want to make sure that you guys receive ribbons to for this work and having this conversation. I've only been on for a little bit, but I can tell you, I appreciate the tone of the conversation. I appreciate that, as you're talking about smoking, that it is clear on this call that you're calling it an addiction, right? There have been too many conversations that I've been a part of where they talk about it as a habit, they talk about it as a lifestyle, and are not willing to say that it's an addiction. We've absolutely proven it, and we've proven how bad and how difficult it is. And so I want to thank all of you guys for being on this call and, committing to this as a part of, this bigger commitment that you've seen from the Great American Smokeout, a bigger commitment from Duke, a bigger commitment from North Carolina, all of the people that came together to make this happen. But even more so, thank you for being committed to it with the right mindset. That you're fighting for people. These are people that are addicted to smoking. That we proved that the system took advantage of them. We proved it at a level where in 1998 the cigarette industry was indicted for $206 billion. Right. So there's no need to blame a victim. The person that is smoking, that is struggling to quit, there is a reason for that. It has been proven. So they need our help. You need our help, and we need to recognize that, unfortunately, smoking is connected with so many different diseases, not just, lung cancer, but so many different cancers, so many other diseases, that it is critical if we care about somebody. That's why we're going to help them. We're not helping them because we just feel bad for them, like there's something wrong with them and we need to do something, but really because we care enough for them to realize that that addiction that is hurting them is something that they need help with. That the numbers and the studies have proven that they need support and potentially need other things. I know we had a great conversation just about some of the smoking cessation aids as it relates to, pharmaceutical products, right? Might need them. But the biggest thing, again, is knowing that it's a person that is dealing with it. It is an addiction and they need our help. So thank you guys for your commitment. Thank you for all of you. It takes a team to be able to get this done. It takes having the right mindset. It takes looking at our people and saying, I care about you so much that's why I'm here for you. I care about you so much. That's why you're on this call. That's why you're a part of this training, because you care enough about people to find out how can you connect a little bit more that can be something transformative in their lives. So thank you guys. Thank you for allowing me to be on and share just for a little bit. And thank you for your commitment to our communities. Thank you for walking beside people and being willing to help them. Thank you.
Thank you so much for sharing that message, Mr. Draft. It's completely understandable why you were named the NFL Alumni Spirit Award in 2006 as the Man of the Year with the Carolina Panthers. So we thank you for all that you do, and we thank you for your dedication to moving the needle forward.
Thank you. Thank you.
I know we have a few questions that were not answered in the chat, and I would be remiss if I did not say this has been an amazing and rich conversation in addition to the training that we have received. And it's not over yet. This is just the beginning. We look forward to moving the needle forward, having the conversations in the space to have these discussions. And if there are any more questions, would you like to share them, Joe?
Yeah, there are a couple of more questions I think were really good. Megan, do you include family members in the support group?
Yes, well, so family members who also smoke are included. So if if we have two people who smoke, they can be included. But because of the nature of the group, we don't include non-smoking family members in that. Now, for individual sessions, we absolutely do, because people can consent to their own family member being part of their individual session. And I do encourage family members to be involved.
Great, thank you. I know there were a couple of more questions, and I also recognize that we're at time. Megan, I know you had shared your email. I hope it's okay if folks email you with more questions.
Oh
if
yeah,
they have them.
absolutely. Mhm.
Yeah, and I also just want to put in a plug for Duke UNC TTS. You can go to dukeunctts.com if you want more training, more information. We'd love to welcome you to some of those as well.
Fantastic. Thank you. And thank you, Megan and Jillian, for all the work that you are doing and the support and the efforts. And they offer an amazing array of trainings that are available. If you visit their website, we will make sure that we share the information and resources with everyone following the call. In addition, please make sure that you have everything in place in regards to your continuing education credits. Please make sure that you have gone to the site and logged in. If you have any technical questions or issues, please feel free to send me an email. I'd be more than happy to help navigate you through that. And again, at the end of the day, what it comes down to is how do we make this better? How do we move it forward? And we're very thankful that you've joined us today. We will have an evaluation for those that are in attendance following the presentation. Thank you again to our panelists. Thank you again for our attendees, and we look forward to speaking with you all and hopefully a part 2 later on. Have a wonderful day, everyone. Bye-bye.